Welcome to this concise video log on caring for an older man with HIV and COPD. This program is provided by Clinical Care Options and is supported by independent educational grants from Gilead Sciences, Merck Sharp and Dohme Corp., and ViiV Healthcare. This vlog was recorded by Dr. Joseph Eron. Please note his disclosures on this slide. This vlog is part of a comprehensive educational program on caring for aging patients with HIV. You can gain CME, CE, or CPE credit for viewing these vlogs and download the slides by visiting our website, clinicaloptions.com.
Hello, I'm Joe Eron. I'm from the University of North Carolina in Chapel Hill. And I just saw a patient who represents a challenging type of case that I often encounter and I'm learning more about. And I'm going to go through some of the details in this video. So here's my patient who I just saw. He's a 66-year-old Latino man. He's diagnosed with HIV in 2004. He was originally treated with efavirenz, FTC, TDF, but he was kind of poorly adherent and not very engaged originally, and rebounded with resistance. And here in the South, we say he had a come to Jesus moment and realized that he'd better take his medications. And so he went on to darunavir, ritonavir, and 2 nucleosides, had excellent adherence, and really since that time has been suppressed on therapy. And over time, we've kind of simplified his therapy, and he's currently on darunavir, cobicistat, TAF, FTC as a single tablet. And on the right of the slide, you can see his CD4 is pretty good. It's not quite above 500, which I've seen in some of my patients as they age. Maybe their CD4 kind of dips a tiny bit. His viral load's been less than 40 for over 10 years. I do know from when he had rebound on efavirenz, FTC, TDF, that he has both a K103N and M184V. His BMI is actually not obese, which is unusual here in North Carolina, though I guess it fits overweight. His CBC is normal. His metabolic panel is normal right now, and he's immune to HBV and he's HCV antibody negative. So at our visit today, he brought something up that he hadn't really talked to me about before. I also kind of function as his primary caregiver, which I do until they get kind of complicated. If they get on more than one diabetes medicine, I tell them they've got to have a diabetes doctor. But what he said is that he's had some trouble keeping up at work. And when I kind of pushed him, he said, well, maybe it's been going on for maybe 2 years. He works in a chicken processing plant, and you got to keep moving there. You know, the stuff is going along on a conveyor belt, and you really got to, do your chopping quickly. And he said there's kind of poor ventilation in the plant, and I wouldn't be surprised if that was true. And then as we're talking, he mentioned these urgent care visits that he's had with some cough and mild wheezing. And each time he gets, once I think he got a Zithro, the other he got amoxicillin, says he got better, and he doesn't wheeze chronically. On history, he is a former smoker, though he stopped 27 years ago. That's when he stopped using methamphetamine and married his current wife. His total pack year history was about 15 pack years, he said, and he hasn't smoked since that time. His only medications are his HIV medications and atorvastatin. His CBC is normal, though his hemoglobin is almost 17, so it's a little higher than maybe. It's still in the normal range. His white count's 5,000, and he does have a few eosinophils, 250 eosinophils. Not a lot, but more than 200. When I looked into the Care Everywhere thing on my Epic, at one of those visits, he did have clear lungs, but had mild hyperinflation on a chest X-ray. So I'm a little worried. I probably would have not done this 2 years ago, but we now have a pulmonologist in our clinic that has sensitized us to the fact that COPD prevalence is actually very common. Even in people without HIV, it's 10 to 12% in people over the age of 65. And of course, our HIV patients are aging. And we all know that tobacco smoke is a risk factor for COPD, but sometimes you forget that secondary smoke is important, and smoke from or other chemicals from home cooking, heating fuels, and maybe from a work environment also contribute to COPD prevalence just in the general population. So these are some data from Brad Drummond and his group. Brad was at Hopkins, but now he's here in North Carolina at UNC, and he did a very large cross-sectional study in 9 cities of people living with HIV. So these are people with HIV, regardless of whether they were smoking or not, and they did spirometry testing, so pulmonary function tests, testing and questionnaires in these individuals. And you can see on the graph that, 2/3 of people had no abnormality on the pulmonary function test, but a little over a quarter actually had obstructive physiology on the pulmonary function test. And this abnormality was associated with age, not surprising, smoking status, and intensity of smoking, and a history of pneumocystis infection, asthma, and the presence of respiratory symptoms. So all these factors are kind of present in my patient. He's above 65. He has a past smoking history, not very intense. And he's now had a history of respiratory symptoms kind of off and on over the last couple of years. So these are data from the Insight START trial. There was a pulmonary sub-study START trial. Remember, START was a large randomized trial, whether we should start antiretroviral therapy in people with high CD4 cell count. So these people had, on average, a CD4 greater than 500, 648. This was a 1,000-person study from 20 countries. These are relatively young people. Median age was 36. About 30% were women. 28% were current smokers, but 61% had actually never smoked. And on the right-hand side of the slide, you can see that the prevalence of COPD was 5% in people that never smoked, and almost 12% in those who were smokers. And you can see that it obviously increases with age, but the prevalence in people who were less than 44 is not trivial. So these kind of data really have sensitized me to really think about COPD in my patients, especially as they age, and to talk to them about their respiratory symptoms in addition to the other things. So I think I've made a case for underdiagnosis of COPD. We should be screening people with respiratory symptoms that are more than just short-lived and related to a well-characterized respiratory infection. Patients with chronic cough, productive of mucus or phlegm, progressive or recurrent shortness of breath, and again, don't just do it in people that have a history of smoking. My patient, will screen him to find out if he has a COPD. There's well kind of delineated markers, mostly using FEV1, but there's a whole series of information you get from spirometry. But if I had to guess, I bet that he'll end up having moderate COPD. And then we have to think about, treatment. And again, I'm not a COPD expert, but at least for people with, mild or moderate COPD, it's pretty straightforward. The recommended initial therapy is an inhaler, usually a combination inhaler with either a long-acting steroid and a long-acting beta agonist. The pulmonologists love these initials, LABA, long-acting beta agonist. And maybe there's also combinations of long-acting beta agonists with long-acting muscarinic antagonists. And whether they need a steroid or not, I know the pulmonologists sometimes use that eosinophil count. Certainly, I have been used to using a steroid inhaler. And there are more recent data that suggests that people might be better off with all three agents, both a long-acting inhaler, a long-acting beta agonist, and a long-acting muscarinic antagonist. And then, of course, with this guy, if we're going to do that using a long-acting steroid inhaler, we have to think about drug interactions and kind of schooling our trainees, our fellows, or residents that inhaled steroids in someone on a PI can cause systemic steroid adverse effects or Cushing's-like syndrome. And on this slide, I just basically know that beclomethasone inhalers are okay. That's what I know, and just about everything else is not okay. Though it's a little bit more subtle than that, and this slide is actually quite helpful. I'm sure those of you with some HIV experience have filled out prior authorizations of why can't your patient have fluticasone or budesonide, and why do you have to have this inhaler that's not as common and typically more expensive on their formularies. But our patient would either need to be on beclomethasone or a similar. My plan is actually I'll switch him to probably, he likes the single tablet, so probably bictegravir TAF FTC. Somebody might say, whoa, this guy has a M184V. You told us that in the very beginning, and you're right. But they're very good data from several different studies, most recently from the BRAVE study that was presented at the virtual CROI, that showed that in people suppressed on a protease inhibitor or other 3-drug therapy, even if they had a nucleoside resistance, including M184V, remain suppressed. So I feel very confident that that will be a good regimen for him. And I do think I probably would not use a 2-drug option in him like dolutegravir 3TC because of the 184V mutation. It certainly would not be recommended by any guidelines in this particular situation. And then you might ask, what about lung cancer in people with HIV? I think there's enough data suggesting that lung cancer has a higher incidence in HIV patients relative to HIV uninfected people. It certainly is diagnosed at an earlier age, and obviously there's higher risk with lower cumulative PAC year history comparing HIV infected people with HIV uninfected people, and survival is actually worse. At least it was. I think we're probably doing better now because we're happier to use more aggressive chemotherapy in HIV patients. But again, there is increased risk. Now, there is screening for lung cancer, which includes low radiation or low dose CT scanning. He doesn't fit, right? You can be between 55 and 77 years old. He's in that range. You can't have signs or symptoms of lung cancer. Then you should do diagnostic screening, not diagnostic testing, not screening. But he doesn't have a 30 PAC year history. He hasn't smoked for 27 years, so he's outside that window. I'll probably have him see our pulmonologist in our clinic, in part because she is embedded in our clinic and she's terrific. So I'm going to send her to see him. I am going to change his therapy so she can use whatever inhaler she'd like to recommend. But just keep in mind that when using steroids of any type, whether they're inhaled or injected or taken orally, to think about drug-drug interactions, especially on people that are on boosted agents, either boosted protease or a boosted integrase inhibitor. So thanks for taking the time to talk about this case with me, and I hope you have a good day.